A lot of questions in on that. I know, Lewis, you're having a look at it, and you mentioned stem cell transplants, and are they still options for CLL patients, and where would they be an option?
So yes, I think the stem cell transplant is still an option, Michael, for some patients, and where it depends on where you are in terms of in the world as well, because in some parts of the world, the CAR T cell therapy is still not there. I would argue that people where you would consider giving somebody CAR T cell therapy, that's where allogeneic stem cell transplant sits as well. So a typical example, for example, people who've had of chemoimmunotherapy, had a BTKI inhibitor like ibrutinib or acalabrutinib, and they're on venetoclax rituximab, which is the standard kind of the route that's being taken at the moment. And I normally check MRD in those patients, and there's ample data now to say that patients who have not achieved the MRD negativity in the second year or third year of therapy, second year of therapy, and in the third year they are off therapy, you have to have opened up those discussions, because once the patients relapse, you only have got PI3 kinase inhibitors, which does not, patients don't respond to that very well when you use there, or you have to go on to a clinical trial. So I really want to have that discussion there with my patient and give them the pros and cons about that. And I might offer them the CAR T cell trial if it is available. The problem with the CAR T cell trials is that they are more frequent in US, and there are lots of new constructs which are coming, which are very good. And I'm aware that the CAR T cell trials would be coming along as a phase 3 trials as compared to venetoclax rituximab. So they are becoming a reality for CLL patients, which is very good news. But I think you need to have those discussions at the right time. You don't want to have that discussion when the disease is in florid relapse.
Okay.
And
I don't know.
I would just add to that making these decisions, and Tal emphasizes, these are all shared medical decisions. And CLL is very much a chess game, and whatever move you're making, you've got to be thinking of your next move and your next move, because it is very rare that you make one move and it's a home run, to use an American analogy, and that's it. It's like we talked about, you kick the can down the road, and then you kick it again, and then you kick it again. And the order and what you do is very important. And the reason that CAR T, as difficult as they can be, they're getting way better. But there are transplants carry with them a higher mortality and a higher morbidity. There's no graft versus host disease with CAR T therapy. So I've still, and I'm sure Tal has seen this too, I've seen patients who failed CAR T who've gone on to transplant and done very well. But I think that's the order that we're doing things in. And all new therapies, when they start as kind of the last, ibrutinib started as kind of at the end of the road, and now it's moved up where it can be frontline in a lot of situations. Not everywhere, but in a lot of places. So I think we'll see the same with CAR T moving up the line as we recognize its value and it's better controlled. So I think it's a very interesting situation, but there still is a role for transplant, but it is kind of the very much an end of the road therapy right now when we've got so many other good therapies ahead of it.
Great, thank you. Lots of good questions here in the Q&A. Feel free to pick a few, but I'll just answer the first one. Is there any further update on antibodies for CLL patients after the vaccine? There's actually a report out. There's a link to it on our websites, which people can access for themselves. We'll be putting a video up in about a week or 10 days' time with the lead researcher talking about this very subject. So please look out for that. Apparently my screen's frozen. What advice do you give? No. There's a couple of things here I've never heard of, but there you go. Something called cryoglobular anemia.
I think that might be hypo.
No, that's cryoglobulinemia.
Oh, it's
I can take that.
I'm going to learn something.
No, cryoglobulins are in explained was these are antibodies which combine with an antigen, and they can deposit in different parts of the body. Normally, we see cryoglobulins in variety of conditions. It's not only CLL related, it could be other autoimmune disorders as well, and sometimes in some viral infections as well. But majority of the cryoglobulins, if they are associated with CLL, they should get better with the CLL-directed therapy. And I think that's what the question is really. Yeah. I would just say that cryoglobulins sometimes are just there and actually are not causing any problems. So if they're not causing any problems, then you don't need to worry about it. But if they are causing some issues, then treating the underlying cause is most probably the right thing to do.
Right, thank you. Something I'd never heard of before, Talha. It was a complete mystery to me. Do you want to take a pop at the Sjögren's syndrome? And the famous, well, Donald Trump should be listening to this, hydroxychloroquine. You know, it's his favorite drug, of course, but have you got any comments on that? Have you seen the question?
Yeah, no, I've seen the question, and yes, Sjögren's syndrome is another autoimmune condition where antibodies attack some of the glands like parotid gland and lacrimal glands, and people have got less saliva and less tears. So a lot of that is related to autoimmune destruction of the glands by these antibodies. And hydroxychloroquine does suppress the immune system to reduce the antibodies production in that condition. It's fine to have it in CLL. I don't think, you know, that's a contraindication to take the tablet, but and I don't think it will have an impact on the CLL itself.
Right. Hope that. So there's a number of vaccine related questions and the efficacy of them. And there's one in particular that's come up. Brian mentioned cocooning. And one of the questions is, of course, you know, I've got children, they're at school. You know, the government doesn't appear to understand about shielding. How should I be handling this? I mean, is there an approach that you'd recommend people take?
So I think Brian told you a very good approach. So Brian's approach is, if my patient says that what Brian is saying, I would be quite happy, because actually they are the most cautious of all patients. But the reality is that actually we have to, you know, come out in some way. And the question is really what is the level of risk that we can take? The problem really with the COVID antibody data is that, one, it is clearly showing that the response is poor as compared to immunocompetent people. There's no doubt about it. But if you look at any vaccine data for CLL patients, that has shown the same thing as well. So this is not only particular to COVID. The other thing I would say is that if you have the vaccine, and the most important thing is to have the vaccine, and the data, Birmingham data, is clearly showing that the time interval is important. So have the vaccine, you know, not 12 weeks apart, have it 1 and 3, you know, have the baseline dose, and 3 to 4 weeks later, you should have the second jab. The amount of response is not great, but it doesn't matter, because if you think about it scientifically, what the vaccines are doing are they're stimulating your immune system. And the immune system then activates to make antibodies. Now, if you have got less number of these immune cells, you will make less antibody, you might have less T cells to play with, but you might have something there. And I would just say that even if you make very few what we call as memory B cells, which is a concept that the scientists find that all these vaccine-induced these memory cells, they stay in your body. And God forbid, if you do get COVID, these memory B cells will reappear and they will mount a good response. At the moment, we are seeing that the response is poor, and hopefully we will have some data on these monoclonal antibodies, which we would be able to offer to some patients. But at the same time, have your vaccines. And I think even if you don't have antibodies, you may still have a good response if you ever get COVID. In terms of living your life, I would still take a cautious approach. I'm not saying to the patients that, you know, have your 2 jabs and out you go. I'm still selling them, be cautious, you know, be proactive, not to go into spaces where your risk of picking up COVID is high. So, and then it is a kind of a discussion that we have depending on what is, you know, appropriate and what is not appropriate. But it comes to individual choice from there on, really.
And let me just add that every test has a level of detection. We talked about that in looking for the CLL. The same is there for antibodies. So they have an arbitrary cutoff. These tests were rushed out. They don't have, some of them don't have the greatest sensitivity and specificity, which means they're not tremendously accurate. So you may have antibodies, they're just below the level of detection. And God forbid the real disease comes along, that may jump up. There has been no correlation between antibody response and how well you do if you're exposed to COVID. There's no data. Now, I don't want to be too fancy about this. It's much better to have antibodies, and odds are if you have antibody response to the vaccine, you're going to do better than if you don't have antibody response to the vaccine. But there isn't any proof of that yet, and there's reasons to be hopeful that the antibodies, even if you don't get a response, will provide some level of protection. Whether it's the same level or not, we don't know at this point. And we're going to collect data on that, and there's a ton of research. So that's why I'm, you know, pitching to be patient about this, because this is being looked into aggressively, and are there ways that we can augment that? And again, it's all, what's your level of risk are you willing to take? And, you know, if you're willing to stay cocooned and shield, you're 100% safe. But some of us can't do that because we have school-age children or school-age grandchildren. So what is the risk from that? And there's never going to be zero risk. I mean, even adult children who are vaccinated may not, you know, the vaccines aren't 100% in the immunocompetent. So could they still shed the virus and could be asymptomatic and give it to you? Yes. Has that been documented to happen? Yeah, it's happened, you know? So, you know, there's nothing that's risk-free. So you have to decide at what level of risk you are willing to take. But the one with kids is a heartbreaking one, and that's a difficult one. That's the most commonly asked, and there isn't a clear answer to that.
Thank you. Michael, any questions?
Well, actually, I thought that was my wife that asked the question, but she told me that she didn't, because we have 2 teenagers that we didn't send back to school. So kind of very controversial over here. She told me she didn't ask the question. I suppose, Tal, if I can ask you about the gold standard. We always heard that the FCR is gold standard, and we've been hearing that for years, and still we hear such outstanding results from all these novel therapies. Any of them treatment options becoming the gold standard now, or is that ever going to change, you know?
So I think FCR is most probably going out of the way now. You know, we have now data that ibrutinib is, with rituximab, is better than FCR based on the E1912 study from US. I can tell you that Flair will be reporting on that as well from UK very soon. So we will get some more data on that. And nearly every trial you look at, the BTK inhibitors are better than chemoimmunotherapy. That is clear. And same is true about venetoclax with obinutuzumab. Now, some people argue that a small group of patients called who have got this IGHV mutated status may still benefit from FCR. But I would argue that if you look at the venetoclax obinutuzumab data, the IGHV mutated patients are doing magnificently well on that combination as well. So, and we are going to get some more data on ibrutinib with venetoclax in a phase 3 trial called GLOW study, and that will be presented by Anand at EHA, which is just this month. So essentially we will get combination data, 18 months of combination data on that. So I personally think FCR is going out of the way now. The issue now really would be whether we ever would be able to use chemoimmunotherapy for CLL patients in relapse setting. So actually the relapse setting data is really, really poor for chemoimmunotherapy.
I suppose if I can just add to that, Brian, sorry, just with the FCR, that if you've had a patient that's on ibrutinib, or maybe they went on venetoclax, is there an option, and failed venetoclax, is there an option of going back on ibrutinib? Or what is the option after a venetoclax? I'm talking about the sequencing of the treatments.
Sorry, Michael, can you repeat that again?
If you had a patient, like I suppose over here in Ireland, when we look at the patient journey through treatment, I mean, the first line option is FCR. If the patient relapses FCR, they're on ibrutinib. If they fail ibrutinib, they might get venetoclax. If they fail venetoclax, what's the option then?
So I think in that case, you're in a difficult situation. It depends on whether the ibrutinib was, patient was relapsing on ibrutinib because they had intolerance, or they were requiring a mutation, a specific mutation where ibrutinib binds to colcystine 481. So if it was intolerance, which means side effects due to ibrutinib, and that's why ibrutinib was stopped, then there is every chance that using an alternative BTK inhibitor like acalabrutinib or zanubrutinib in that setting will work. And the data looks very good from that perspective. If patient is on venetoclax and stop therapy at 2 years, like with the Murano data, and then they relapse a year, 2 years down the line, then the data for venetoclax retreatment looks very good again. So that is option as well. But I think that's the kind of patient that I would really talk to them about CAR T cells and allogeneic stem cell transplant, how to get them there. In some patients, I'm trying to use LOXA 305 to induce remission, and the data looks very good from that perspective. But like what Brian was saying, that it was just pushing it down the line, I'm thinking about what next. Can I salvage this patient with CAR T cell therapy? And that is what the next step would be.
I mean, I love the idea of these sort of future treatments that are coming down the pipeline. But is there a roadmap? I know it would have to be personalized for me, Lewis Troke, but so we've got a standard roadmap, and Lewis, you're going to take this small diversion or something like this. But are we there yet, or is there still a way to go on that?
There's still a way to go, Lewis, and I think the problem is that LOXO is now going to be coming forward, and their phase 3 trial is looking at venetoclax rituximab versus venetoclax rituximab with LOXO, and I'm pretty sure that they will move to the frontline setting as well. And we have data on patients who relapsed on ibrutinib and venetoclax and then had LOXO, but we don't have data vice versa at the moment, and that is a problem we will have in future. So those distractions will happen, and will happen for a good reason, because the new molecules might be better than the molecules we had in the past. But that's why the research is so important, and that's why clinical trials are important to identify those things. So I think there are some molecules we have clearly have got BTK inhibitors, we've got venetoclax, and we've got CAR T cells. Individually, these groups, all patients should benefit from these groups individually. That's clear to us. In each of these groups, the different molecules which are coming along, some might have different benefits, some might have less side effects, and we just have to play around with that and see which is the right drug and right thing for our patients. And that is what's happening in CLL at this moment in time.
Brian, what's your view on the roadmap thing?
Well, I would echo what Tal said, that roadmap has to be individualized. And when you're looking at any treatment plan, you've got to look and say, how do I fit in? Look at your age, look at your comorbidities, look at your personal preferences, and then see where you would fit into some of these roadmaps that are put together by IWCLL or NCCN and some of the guidelines. And some of the countries have formularies that kind of force your hand, but try to see where you fit in or don't fit in. I would also echo what Tal said, is that clinical trials are parts of this roadmap on every piece of every step, including when you're first diagnosed. There's natural history trials. There's trials now looking at high-risk patients of early intervention, and maybe we have better drugs. Is watch and wait still the right approach for people? There's trials that are looking at this. There are frontline therapies that are being looked at. So there's all different kinds of things. And the only way the science is going to get better is with clinical trials. And we only have so many kicks of the can down the road. I keep coming back to that analogy. And the cans that we're kicking have much better aerodynamics and are flying much further, to push this analogy, and we're doing way better, but there's only so many of them, and we need to get more of them out there. And that's why clinical trials are so important. And Tal talked on this. We're almost a victim of our own success. We have treatments that are so darn good that if you compare yourself to ibrutinib and you're a new drug coming along, how are you going to do that? And the pharmaceutical companies say, well, maybe I'll look at mantle cell lymphoma. Not that mantle cell doesn't have a need, but they're saying, CLL is a little high of a bar to get across. So they're looking at other, disease states, and there's less research going on in CLL. And that's why we've got to accrue these trials and push these trials forward and be active as patients, because that's the only way we're going to get to having, a functional cure for the 70% of us who don't have a very indolent disease.
Okay, thank you. Michael?
I suppose, I'm kind of going through the questions here, and, it's very hard to cover every angle on it. Tal, would you say which vaccine would be the best? And just to let you know that many patients here in Ireland, CLL patients, have had their first dose of AstraZeneca. And is it more preferable now that they move to the Pfizer or going forward?
I don't think so. I think the data for vaccines are, all of them are showing good responses. I think for younger patients, really the Pfizer or Moderna is better. Just because of the side effect profile of the vaccine, but the immune responses have been equal really with any vaccine. So I personally don't think that people should move to a different vaccine, but for the younger patients, I would definitely say that, the Pfizer or Moderna is the better option as compared to the AstraZeneca or the vaccines where adenovirus vector is being used to construct the vaccine. So but that's the line which is being taken in UK anyway, and for other reasons which we all are aware of. I think I just have seen one of the questions and one of the comments was made about the squamous cell carcinoma removed from legs, and I've said that it will be more frequent. No, I don't think I've said that. I think what I've said is that you just need to be very careful, and what I tell my patients that your skin is very sensitive. And just be careful and make sure that if there is any new lesion, then go and see your GP sooner rather than later. But it doesn't mean to say that this will recur or anything like that.
Okay. What about you made a comment when you were talking about the interval between first and second vaccines, and there's somebody here saying they had to wait 14 weeks. Is that an issue?
I think the Birmingham data is raising that question that if you give 2 jabs at a shorter interval, then you are actually getting a quicker response as compared to when you space out your 2 doses. And I must say that, I've always thought that increasing the frequency, the timing between the 2 doses may be fine for immunocompetent people, because actually their immune systems they don't need a lot of shove to boost a response, whereas patients with low immune system, that interval was too long. So I do think that, the data is telling us. I think the good thing would be that the boosters might be coming. I know that on clinical trials, there are already booster doses, and there is mixing and matching happening at the moment. So there is a trial looking at using 1 dose of Pfizer and the other dose of AstraZeneca. And then there are other things which are happening, like Novavax, I know, is changed the vaccine in such a way that the booster dose will incorporate the Indian and the South African variant. So all of that will give us more data. And, if I'm a big believer in trials, so when the trials came along, I participated in Novavax trial. So, it's one of those things where we have to learn more from these trials and try to get more data. But I do think, yes, the interval between the 2 doses for immunosuppressed patients, I think it needs to be 3 to 4 weeks, and then Birmingham data is supportive of that.
Let me just add a little to that. First, I think that there will be data coming out on vaccine efficacy from the LLS and other people relatively soon. So stay tuned, and we can only say what we know now, but I think people are looking at these issues. So the second is, and tell me if I'm wrong on this, Dr. Munir, but my understanding is the advantage to getting the vaccine sooner is that you don't have that extra 9 or 12 weeks of being exposed where you're not protected. But ultimately, 2 weeks after you get that second vaccine, you're protected at the same level, whether you got it at 3 weeks, 4 weeks, or 12 weeks. You're ultimately protected at the same level. It's just that you're exposed for an extra couple months in there. Is that a correct understanding of that?
It is a correct interpretation. I think the other thing to say is that when you vaccinate at a shorter interval, then you are stimulating the immune system with the antigen very quickly. So you might get a better response in immunosuppressed patients. But all of these questions really should be looked at in a trial setting, and we do not have head-to-head data in this setting. But you're right, Brian.
Okay, Michael, do you have any other questions you want to ask?
Oh yeah, well I suppose look, the big conversation that was happening when vitamin D for CLL patients, and actually probably not CLL patients, all of us, with the risk of COVID and help if someone gets COVID. Can you maybe explain how that works?
Vitamin D is quite interesting in terms of that. If you look at all the vitamin D data, it is quite clear that with vitamin D supplementation works for people with getting frequent chest infections, and there is good data on that. And there is not a lot of actually data in COVID whether vitamin D makes a lot of difference, but I think there is ample data to say that the vitamin D supplementation reduces the risk of chest infections in patients, which is not only for CLL patients, other patients as well. So I think overall, it was a policy that was derived to reduce the risk of infections in patients.
And I would add that there's studies out of Mayo that showed people who had adequate levels of vitamin D when they were diagnosed with CLL had a more indolent, slow-growing course. There was no data that said taking a vitamin D supplement slowed down their CLL, but it just makes sense. So I take a vitamin D supplement, but so does my wife who doesn't have CLL and my kids who don't have CLL. I just think it's good because we're also being very careful about our sun exposure because we have that risk of second skin cancers. So I can't get it the natural way. So I take a supplement and I check my levels to make sure they're in the normal range.
Gentlemen, I'd like to really thank you for your time today. Your contributions have been incredible. For those of you that have asked a question on the Q&A that we haven't answered, please rest assured that what we do is we take those questions and we answer as best we can and publish the answers on the website. Look out for the Birmingham study paper, which is referenced on our website now. It will be in the newsletter later. And look out for the video. We've asked Dr. Helen Parry, who is the lead author of the paper, to talk, and she'll be producing a video for us in the very near future. Just before we move to the poll, which I'd like Maurice to tee up while we're talking, perhaps Tal and Brian would like to just, final thoughts before we close down the webinar. Or would you rather have another question?
I can take first. Thank you again for this opportunity, and great to see Tal again. And I love working with you. I always learn things when I'm with you. And I'm just going to say what Michael has heard me say many times. There's never a good time to be diagnosed with CLL, but there's never been a better time. The treatments are getting incredibly targeted, specific, individualized, and offering us, the majority of us, the possibility to die with our CLL, not from our CLL. That doesn't mean that we don't have issues in terms of immunocompromise, second cancers, other things. That doesn't mean we have to make important treatment choices. And it doesn't mean that some of us won't succumb to the disease, but there's never been a better time. But it is an orphan disease, and you can't be guaranteed that you're going to get the best treatment by going to your community doctor who maybe sees 1 or 2 CLL cases a year. So at the CLL Society, and I think CLL Ireland and CLL Support are behind us in this, we promote novel targeted therapies, we promote expert care, and we promote clinical trials, because we think that those are the 3 pathways. And in order to do all of that, you have to be, as Michael says, an informed patient. And your doctor is busy, your oncologist taking care of breast cancer, prostate cancer, colon cancer, the big 4 cancers that they see all the time, they don't see that much CLL. So if you see a Dr. Munir, if you see Dr. Thornton, Professor Thornton, you're going to get someone who wakes up in the morning thinking about CLL and goes to sleep thinking about CLL. And that's what you do as the patient too. You want a doctor on your side who thinks that way and feels that way. That's so important to do that. And in some health systems, that's harder than others, but sometimes bluntly, if you can afford it, look to pay out of pocket, look for what options you have, even just to get a one-time consult to make sure you're in the right direction. I can't emphasize that enough. There's studies out of Mayo Clinic that show if you have an expert on your team, there is a very significant survival advantage for the CLL patient. So I'll finish with that. And again, thank everyone for the opportunity to be here on behalf of CLL Society, and great to work with my friends across the Atlantic.
Oh,
Yep, it's always difficult to follow up from what Brian says, but I think I just like to thank for being with you guys today. And all I can say is that I would agree that the CLL patients, we are seeing a decade where we had so many improvements which have come along for our patients. And I would like to see the next decade just rolling on from that point of view, to get more treatments for our patients that we can offer to our patients. And individualized therapy is what I hope that every CLL patient gets. And hopefully we can achieve that in the near future.
well, amen to that. So, gentlemen, again, thank you very, very much indeed for your time and contributions today.